What's up everyone, my name's Hunter. I am a first year emergency medicine resident and we have been reacting to season 2 of the PITT. Let's watch episode 13.
You know this guy?
Orlando Diaz. We were treating him for DKA when he eloped.
How far did he fall?
20 feet or so.
Anyone see him pass out?
No, they went looking for him after he didn't answer his radio.
You're both equal but sluggish. He left against medical advice.
On my count. 3, 2, 1. Dr. Ellis on the case. Day shift, we got this.
I'm staying.
Continuity of care. Dr. Alice, Jimmy, why don't you go cover Senate rounds with Dr. Abbott? Chen, you too?
Got it.
Okay, let me know if you need anything.
Lungs are up bilaterally.
Pelvis is stable. Right tip fib hematoma. Deformed right forearm.
Ruptured GM on the left posterior sanguineous fluid.
It means baseless skull fracture.
We've got a diabetic patient, 20-foot fall.
BP 204 over 98. Pulse 56. Dr. Mohan, what do those numbers indicate?
I'm trying to treat the patient. The Cushing's reflex.
From increased intracranial pressure.
Yeah, we need to get him to CT right away.
No free fluid in the belly.
Any family to notify?
Wife and 3 kids. Plain films, right tip fib and right forearm after CT.
Got the Chem 8. Blood sugar's 284.
That's not too bad. Potassium looks good.
Any gaps up at 14.
It was 24 this morning. He's definitely improving.
The DKA is resolving.
So what made him pass out? It's hot as hell out there. He could have been dehydrated from sweating, or he could have had an NSTEMI or a posterior CVA.
Ready to roll?
I could babysit him at CT.
Thank you. I'll stay in case he needs the OR.
I think they did a really good job of covering everything as that patient rolled in. We know this patient from previous episodes. I don't really have a whole lot to add, honestly. They did a very good assessment, did a primary survey, secondary survey, noted a hemotympanum with CSF fluid leak, just meaning that there's blood behind the eardrum, really concerning for a basilar skull fracture, which is a fracture of the base of the skull. Needing to go to CT, will possibly need a neurosurgeon, and they're on their way now.
How are you doing, Oliver?
Alive and kicking.
Mr. Haas, pulmonary edema after missed dialysis, now stable with his son Mason at the bedside.
Hello.
I'm Dr. Shen. I'll be back.
Dialysis tech says I'm off the machine at 10:42.
Hit the call light and I'll come running.
South 21 next. Mr. Digby.
Just Digby.
Dr. Mohan's patient, forearm cellulitis, admit med-surg awaiting a bed.
I can take him.
Sold. Dr. Tamarian. Moving right along.
Good enough to eat? We'll be back.
Lillian Stegman, tweet your knee water skiing.
Doing a 360 off a 5-foot ramp.
Respect.
X-rays ordered in triage. That was hours ago.
Ma'am, I'm Dr. Cruz Henderson. Let's get you home real fast.
That would be wonderful.
Okay, heading to north. It's like our first scanning station is almost ready. Whitaker Santos, after rounds, this will be your post.
Seriously?
For how long?
So we mop up this mess. And away we go.
All right. Now you know everything there is to know about rounds. Fascinating, right?
So rounds in this sense is the handoff between the day team and the night team. This is commonly cited as one of the times during medicine where the most mistakes are made, simply because this handoff is very difficult. You have one provider that has been caring for a patient, knows their whole story, and had a plan for their workup and ultimate disposition, and then they end up having to hand all of that off to the next person that's going to be taking care of them, and inevitably things can get missed, drop through the cracks, and lead to worse outcomes. So it's really important that this handoff happens, and it's usually a very formal process. It is different in every department. I've seen where they do rounds like this, where they actually go to the patient bedside and do the handoff there. I've also seen what we do at my hospital, which is more of like a table rounds where we run the list as a team and assign who is going to be taking which patient and do the handoff there. Any which way you spin it, it's just really important that this handoff happens, that it's uninterrupted, and is done in a concise way, but in a way that portrays all of the pertinent information that the oncoming person needs to know to be able to take good care of this patient. So glad to see that they're doing it. They obviously haven't touched on every patient in the department, but it looked pretty good from my standpoint.
Grady Barnhill, wheezing and not responding to albuterol. Pulse ox 87 is Mother Naomi.
Okay, trauma 2's open.
On our way. Mom, history of asthma?
His whole life. Never this fast.
Barely moving air.
Using all his accessory muscles.
Cole RT. Continuous nebs, 20 milligrams an hour.
Yeah, the whole nebulizer. I've been giving him albuterol every hour.
Ready? On my count. 1, 2, 3.
Does he take any other medications?
Just the albuterol. He used to be on Montelukast and Symbicort.
Why did you stop that?
Because he lost his Medicaid 2 months ago.
So tight, nothing's getting through. Mel, EpiPen?
On it.
0.3 milligrams.
That may open his lungs so the nebs can work.
All right, Grady, shot in the thigh.
So here we have what looks like a pediatric patient coming in with asthma, and it's not controlled by his home albuterol nebulizer. It sounds like we were also supposed to be on some steroid medications as well, so presumably this patient has a fairly moderate to severe form of asthma, and we hear all the time that a patient ran out of their medication, whether it be an inhaler for asthma or COPD or some other sort of medication for a different condition, and then they wait and are unable to get their medication, and then they get an exacerbation of their condition. And so they're doing all the right things again here in this case of continuous albuterol nebulizers, epinephrine to help open up the airways. Overall, good management of the asthma exacerbation so far.
Hi, Mrs. Davis. I am Dr. McKay. This is Dr. Chimerian. Hello. Your labs show a lot of inflammation in your liver. So I am so nauseated. Definitely, yeah. Have you noticed a change in your skin coloration? I've been using this bronzing cream, so I don't look like a ghost in my bathing suit. Do you remember the name of the bronzer? It could have a chemical that can cause it. No, it's 100% natural. It's DHA from sugar beets. Why would my liver be inflamed? There's a lot of possibilities. Are you taking any prescription medications? Not a single one. Tylenol? God, no. We have to ask everybody about injection drug use. Never. Raw clams or oysters? I'm a vegan. One step at a time.
They're asking all the right questions. This patient has lab values that would suggest acute liver injury or failure. They didn't voice what they were, so I'm not sure. But you can tell that the patient has a jaundiced look to her. She is probably attributing the change in skin color to this bronzer that she's been using, but this yellow skin tone that she has is not normal. You can also notice that she has kernicterus, which is jaundice of the eye. The sclera kind of turns a yellow color, so very concerning for an acute liver injury, and they're asking all these questions of, medications, drugs, different behaviors that could cause injury to the liver, but the differential is wide open right now. I mean, there could be cancer of like the pancreas that is compressing the ducts to the liver and causing buildup of all of the enzymes and things that the liver produces, and that can cause liver failure. So wide open differential. Interesting to see where this case will go.
He's brain swelling with effacement and compression of the ventricles.
C-spine, chest, abdomen, pelvis.
Left pulmonary contusion, no intra-abdominal hemorrhage.
Which means I'm off the hook. I'll send neurosurgery down. If he doesn't need the OR, why neurosurgery?
Wait and see.
Let's get busy. CVP to an art line.
Orlando, squeeze my hand. Open your eyes.
We already know his GCS is going to be 3.
Hey, Giovanni, anti-seizure prophylaxis?
Keprach, and he makes for Kilo.
Mixing it now.
Gotta get this brain swelling down, Samira. How are we gonna do that? Samira,
What?
we have to lower the intracranial pressure.
Hypertonics.
Mannitol.
Not the best, can cause diuresis and hypertension.
And hypertonic saline.
23%, 50 cc's through the central line.
A rare but sometimes possible complication of the treatment of diabetic ketoacidosis is cerebral edema. It's more common in peds patients, but obviously can happen in adults as well. And so the brain ends up swelling and causing compression of a bunch of important structures, and you can have a coma from it. And it seems like they were concerned that there was a medical event that led to a fall that would result in trauma, but he doesn't have any head bleeds, which is reassuring. But the downside is that he has edema of the brain, and they really need to act quickly to get this swelling under control so that permanent damage doesn't take place.
You
can have one more EpiPen.
Stats are borderline, 87.
How about BiPAP, 10/5?
Yes, with inline nebs.
All right, Grady, shot number 2.
Might as well throw in some magnesium, 50 per kilo.
I'm sorry, he's not ventilating. We should be ready to intubate.
With an asthma patient, there's a high risk of cardiac arrest.
Naomi, has he ever been put on a breathing machine before?
Never.
Hospitalized?
No, we could always break him with a Symbicort.
We're gonna give the current treatment a few more minutes to help him drink.
They were absolutely correct in making that statement. Whenever we have patients that are asthmatic, COPD, DKA, any like high respiratory drive condition, it's very dangerous to intubate these patients because we often can't do with the ventilator what they are able to do with their bodies. And so they are at very high risk of decompensation and cardiac arrest. So we do all of the treatments that we possibly can before thinking about intubating these patients, just because it's a very dangerous situation.
I could probably do this myself now that my cast is off.
That's okay. I don't mind.
How long have you been a nurse?
This is my first day.
You're doing really good.
Thank you.
You could tell that that meant a lot to her, and it's an incredible thing to hear this from patients and just anyone in the hospital in general. As a first-year resident, there are often times when I am faced with imposter syndrome, wondering if I actually am like at the level that I should be at any given moment. And anytime that we hear from a patient that we're doing really well, or from a colleague that we're performing as we should be or above the level that we should be, it's just like an incredible weight off your shoulders, and I just really can't vocalize how much it means to hear that.
Hypertonics in.
Maintenance LR in the AC.
Looks like a halo sign.
Cerebrospinal fluid from a basilar skull fracture.
Well, the halo sign is neither sensitive nor specific for CSF. Saline, tap water, and runny noses all separate from blood.
Hello, Linda.
Robbie?
Vision chief working on the holiday weekend.
Well, somebody's got to. Saw the scans. This guy needs an EVD.
External ventricular drain to take down the pressure.
Because CPP equals MAP minus ICP.
Cerebral perfusion pressure in the brain equals mean arterial blood pressure minus the pressure in the skull.
ICP less than 22 predicts survival and favorable outcome. CPP from 60 to 70 reduces morbidity and mortality. Can somebody assist?
Dr. Mohan.
I'm good.
So Mary should lend a hand.
I said I'm good.
Javati.
I don't think so.
Chavati? As in daughter of Raymond and Eileen? I was at your mother's baby shower. She was a resident. You were in utero. I don't know how she got through motherhood and training. Feel free to join me.
Oh, my shift was over a while ago.
Okay, masks all around, 2 sterile gowns. We brought the surgical towels, just need some betadine.
This is really weird. I get that Samira is like too emotionally involved with this case and probably feels like she could have done better, which honestly, there's really nothing that she could have done in her earlier visit with him to get him to stay and get treatment. And honestly, I don't know that it would have changed a whole lot other than he would have been monitored when this happened rather than falling 20 feet. For Javati, as a med student, to pass up this opportunity, like, yes, we've talked about in previous episodes, setting boundaries, going home, and taking care of yourself. But this kind of is the time to impress upon these programs that you want to do your residency at. And when a procedure like a neurosurgical procedure jumps and you have the opportunity to do that, you should probably drop everything you're doing to be able to participate, because you're not going to be able to do that very frequently. Like, opportunity doesn't come very often. But also, shying away from procedures and opportunities is a good way to get kind of a bad mark on your application for residencies.
I'm exhausted.
Chief of neurosurgery is here. She's kind of a legend.
Maybe one of the night residents can do it?
Is this about the volvulus case from earlier? Because if it is, you made a mistake. You need to move on. I do not want to come back here and find that you've applied for a residency in derm. Step up to the plate. Do it.
Giovanni will assist.
Excellent. You know, I think Eileen did her first DVD with me back when I was a brand new assistant professor. Time flies.
One thing that I'm not sure of, but I've also not heard of, is an EVD being placed at the bedside. Like, I'm pretty sure that at our institution it always happens in the OR. I might be wrong there. But so for the neurosurgeon to come to the trauma bay to do this feels a little inaccurate.
How fast can you get back?
2 minutes if I take the stairs. Go.
Aerogen? It has a 5mm mesh that vibrates over 120,000 times per second.
Dr. Al-Hashimi.
You okay?
Oh, you're telling us about Aerogen?
Dr. Shen can explain.
It produces droplets in the 2 to 5 micron range.
It was the first or second episode of this season that we saw while, I believe it was episode 2, when Dr. Halashimi was getting the results from the baby Jane Doe. She had this staring spell. And then later we saw her on the phone with a neurology group. And what she just did there was similar to that first episode. And it seems as though she's having some absence seizures and presumably sees a neurologist for some epilepsy. And now that she's experiencing it on shift, this feels like very unsafe for her to be managing patients when her seizure condition is having breakthrough episodes and is not optimally managed. And then for the case of the asthmatic kid, they were asking him if he was tired, because often what happens in these people is you will hear that there's no wheezing in the lungs anymore, and that's actually a really bad sign because it means that they're not moving air at all and they tire out and just simply aren't able to breathe. And this is where it becomes like a very dire situation, and often they get intubated, even though we really wanted to stave it off as much as possible. And there are some other like last-ditch effort things. I'm not very familiar with the Aerogen, so I can't really speak on that. But we're kind of at that point where we might need to intubate.
How's it going?
Just about to start.
Securing the art line here.
Measure twice, cut once. We enter 11 centimeters back from the nasum, 3 centimeters lateral.
Without any direct imaging?
Nope, straight shot into the lateral ventricle. Tried and true since 1890. Okay, go ahead with the incision.
Hey, you worked with Dr. Elishimi at the VA?
I did.
For how long?
During my R2 rotation and then one again last year.
Okay. Handrails all set?
Maybe you should do this part?
No, there's a safety stop here. You can't go too deep. It's not brain surgery. Okay. Stay perpendicular. Okay. Good. All right, now 4 turns to get through the outer table.
Yep.
Then half turns till you penetrate the skull.
So what they're doing there is drilling a hole through the skull so that they can place the extraventricular drain through that hole into the ventricle and allow for decompression by draining CSF fluid out of that drain. It's similar to, if you've watched Grey's Anatomy, the very early seasons, they talk a lot about burr holes. It's not something that we typically do. We don't do it anymore, but drilling burr holes into the skull to relieve pressure, it's similar that they're putting a burr hole in to put in a drain, but very small hole to get a small drain through and into the ventricle.
Definitely improving.
Tidal volume's up.
Wheeze is now expiratory only.
Oh, making some progress.
You feeling better, baby? You scared the shit out of me.
Language.
Does he have a primary care doctor?
Not anymore.
How do you get his prescriptions we need?
Neighborhood clinic. We pay cash. Albuterol's cheap.
Symbol court.
Without Medicaid, $400 a month.
Just for a little inhaler?
Shots down 83.
What's happening?
Give us a minute.
He's tiring out. Ketamine and rock. It's time to intubate.
A couple?
Ma'am, we have to put a tube down your son's windpipe so a machine can breathe for him.
Oh my God.
Hold on. No lung sliding on the right.
Pneumothorax.
No need to intubate.
What's going on?
He has a collapsed lung.
There was no history of trauma that would have caused the pneumothorax.
Flub up, Dr. K.
This is something that can be common with asthmatics and COPD exacerbations. The reason that asthmatics and people with COPD have trouble with breathing is because mainly it's getting air out that is difficult. So they do what is called air trapping, where the little sacs of the lungs, the alveoli, they fill up with air, but because of how restricted all of our airways are, they can't completely get the air out. And so every breath you take, they're getting more and more swollen, and at some point you can have a rupture of some of those sacs, causing an air leak into the chest cavity. We've seen many pneumothoraces on this show so far, and we're seeing another one. So they're going to want to get, in this case, you wouldn't want to just like jump to the like easy Thoravent. Like you would want a chest tube in this to get the air out quickly. And honestly, you would just do a finger thoracostomy to vent the chest quickly and get the air out so that the lung can re-expand. When you have a pneumothorax, it's going to continue to fill the chest cavity with air, collapsing the lung further and further, and eventually it'll actually shift and cause compression of the heart and cause an obstructive process. We call this a tension pneumothorax, and that can also cause a code. So we've got a lot of different factors here that are complicating this patient's care, but assessing or fixing this pneumothorax has got to be the main priority right now.
In asthma, you can get air trapping. When the lungs can't fully exhale, eventually they overinflate, causing some of the tiny air sacs to burst.
How do you fix it?
It's as if I just said that.
Like that.
Just like that.
Dr. Mohan, Lori Diaz is here. She wants to see your husband. She's heading back.
Okay, I'm on my way.
Mrs. Diaz?
Hi. Did Orlando go up to his room yet?
No.
I brought him some dinner from Purgatory. It's a chicken burger. No bun, just lettuce. Figured it would be better than hospital food.
This is where sensitive conversations, and as a physician being able to have these conversations, is really important. In this case, this woman thought that her husband stayed here in the ED to get the treatment he needed and would be admitted to the hospital and go upstairs. And while she was gone, he left AMA and resulted coming back in a much worse state. And so in a conversation like this, you want to have the person that you're breaking news to in a private space, whether it be in the patient room or in like a family room. Want to be seated so that you're at the same level as the person that you're speaking to. Get to the same level of the story. So, I mean, in this case, she kind of already knows what information the wife knows, but in a case where we don't, we often ask, what do you know about what has happened to your loved one? And so then we can kind of figure out exactly what stage of the process that they are aware of, and then you can fill them in on any details. And I'm interested to see how they approach this conversation in the show.
He's being treated by our top brain injury specialist.
Will he wake up?
We won't know for several weeks.
And then he could be back to normal.
Best case scenario, it would take about a year before he could be independent at home.
And the worst case?
Round-the-clock nursing care for severe disability.
You let him leave?
He insisted on leaving to work at a second job.
You didn't make him stay.
He was competent. He knew the risks. We honored his decision to leave.
Even if he was a stupid boy.
I tried to stop him. Offered to get him all the supplies he needed to take care of himself at home. But he left before I could give them to him. He said he couldn't afford to lose a paycheck.
This is a very unfortunate situation, and obviously they just jumped right into giving this news at the bedside, which I think was reasonable in this case. But their conversation right there highlighted a very pertinent fact about emergency medicine and just medicine in general, and that's that if a patient has decision-making capacity and wants to leave or doesn't want to receive care, we have to honor that decision in most cases. And so in this case, Orlando knew the risks of what would happen if he left and still decided that he wanted to do that. And we as physicians can be very frustrated when we try to do everything that we can to educate a patient on the risks and benefits of treatment and what our recommendations are. But at the end of the day, patients are allowed to make stupid decisions, and sometimes they do, and we end up seeing them in a much worse state.
Dr. Langdon? Are you okay?
Yeah, I'm just kind of, wondering if I'm really ready to be back here.
Well, of course you are.
10 months is a long time. I almost killed that kid with an intubation. Didn't even occur to me to check for pneumothorax.
Well, there isn't any trauma to indicate.
I should have caught it.
Now, he's right that that should have been something that he would think about in that situation, and it's very common to beat yourself up after a miss like that, but this is also why we have training programs and why we are in residency, is to learn all of these things. Honestly, it's to make mistakes and learn from them so that you don't when you are practicing as a solo physician and don't have the oversight of another attending or more senior resident to catch these misses that you have.
We don't always get everything right first time. You would have caught the collapsed lung. And it may have taken a minute, but you would have saved him.
Not sure Robbie would agree with you. He's been riding me all day.
Well, Robbie's leaving for 3 months. And, you know, with Robbie gone, I really don't want you to leave either. That which does not kill me makes me stronger.
Wow. Frederick Nietzsche.
Yeah? Nietzsche, yeah. Not Kelly Clarkson.
Sleep Maxine, really? I track the online trends. Is that your secret for the tough ones? I just think, what's the stupidest thing this person could have done? And assume they did it. Well, I mean, she was trying to be healthy. Yeah, by taking advice from fools. Turmeric is recommended by a lot of doctors. Yeah, then ask your doctor for the dose. Or check someplace reputable like the CDC. Oh, right, I forgot. It's a medical toxic waste site. She's in pretty bad shape. Things get worse, she could need a liver transplant. Oh, because she's a big fucking idiot. Wow. No, I actually appreciate her. Our job security depends on all these big fucking idiots. Okay.
I would say that Santos is not wrong in that we do have good job security as emergency medicine physicians, but I look at it very differently in that a lot of people do things that doctors might seemingly think are stupid ideas or, you know, just things that people shouldn't do, but other people don't have the education about those things to understand that it might be a bad idea. And so by painting someone as an idiot because they didn't know seems very unfair. It's not even that they are ignorant, it's that they didn't know to look. It's just being naive and not understanding the risks, even though there may be some benefits to some different supplements or practices. It's hard to know if we don't have the education. And so just like I don't know the intricacies of being an electrician, I wouldn't expect an electrician to know the intricacies of medicine. And so to paint patients as idiots for doing things that make them end up in the ER is just very unprofessional, and I don't agree with it at all.
Good night, Perla. Monica.
Good night, Dr. Robbie.
Good night.
Bye, Emma.
You could stay to pitch in.
Dana told me to go and get some rest before tomorrow's shift.
Yeah, you had quite a day.
Wasn't so bad.
Why can't I find Duke's results?
Oh, new patient, no EHR yet.
I can run over to radiology, get a printout.
Thank you, Monica.
I would think that with the system being online now, you would be able to go into the PACS system. There's fancy, there's like a cloud version for storage of all of the radiology studies. And Dr. Robbie could go in and look at the CT himself. I mean, he kind of knows that he's looking for structural abnormalities in the neck. And sometimes it takes a radiologist to diagnose some very specific and niche things. But as emergency medicine providers, we do read a lot of our own scans and make decisions on management of patients before we get the results from a radiologist. They can be super busy and it can take hours for reads to come back sometimes. And in the case of Duke, it's not that urgent of a matter, but there are times when we need to see the scan and make decisions on what to do very quickly, and sometimes we just don't have the radiologist to guide us in that decision making.
Okay, so he's got a shot at a decent outcome at least.
You think he has a chance?
Oh, I don't know that survival was the outcome he was hoping for.
What?
Told Samir he's got $100,000 in medical debt. That his life is probably...
Mrs. Diaz. How can we help you?
The bathroom?
Yeah, Pearlie can show you the way. What a great idea to have a private conversation about a patient in a public area. You were about to...
Funny that they say that because they do this all the time during the show.
Due to his injury, things have changed.
I was looking for Dr. Abbott.
I haven't seen him for a while.
Excuse me.
So now with a long-term disability, things may be easier.
Easier.
His condition will qualify him for Medicare and Medicaid, so moving forward, costs should be covered, including home health care.
Perhaps this isn't the best time
I just wanted to reassure you about future costs.
Obviously, cost is a concern and a messed up situation that we are dealing with, but not the time to be addressing that with the patient's wife. I think she really only cares whether he's going to be okay and not whether he can afford to cover it. And it was more so earlier, he was the one that was concerned about the cost, not his wife. So that conversation did not need to happen right there.
Hey, Ogilvy. Ogilvy. You okay, man? First day here as a med student. There was a patient. He was a really nice guy, came in with belly pain. I saw a gallstone on the ultrasound, normal EKG, troponin. The pain resolved, and he was in the hall when he had a cardiac arrest. I couldn't save him. People die. And we do the best we can, but people die.
You ever get used to that?
No. No, you try to accept it. You try to find balance.
I don't know if I can take another day like today. Primary care specialty sounds way better. Peds, maybe.
Yeah, maybe. I know I'd be bored out of my fucking mind. Seriously, I like the challenge of undiagnosed illness, of quick decisions, of life-saving procedures. And I like being here for people on the worst days of their lives. You know what I think?
What?
I think you should go home. I think you should sleep on it, and I think you should at least wait till the morning to decide if you want to come back.
I don't really want to go back in there and see anybody.
Yeah. Okay, pull off your gown. I'll take it in. Shift is over. Go home.
I think that scene perfectly highlighted a bunch of the pros of emergency medicine. Whitaker kind of explained a lot of the reasons that a lot of people go into emergency medicine, while still acknowledging that there are very difficult parts of the job that we do, and the importance of acknowledging those and knowing how to work through them, leaning on the people that we have around us, and it also makes the job that we do just that much more special.
2 for discharge.
Yeah, please don't ring the bell. The computers are back up and running.
Not for these 2. They don't have electronic health records yet.
Oh, wait, hold up. This kid had a wrist x-ray ordered. Ugh, it never happened. And water skiing lady's still waiting on a knee series.
I canceled the x-rays. Diagnosed them both with ultrasound.
Really?
Yeah. The little boy had a simple buccal fracture, distal radius. He got a Velcro splint. And Mrs. Stegman had a small medial meniscus tear. The immobilizer crutches and a follow-up with ortho.
Could have used you on the day shift today.
They don't teach us a lot of musculoskeletal ultrasound.
I know. That's why I did electives at Harvard and Highland.
Are you applying for an ultrasound fellowship here?
I am, but it is so competitive.
That's what I hear.
Kind of a long shot. I only have 1 publication, but it's a series of case reports diagnosing shoulder dislocations with ultrasound only. If you want to learn some MSK, you can tag along. I got 3 more to scan.
Maybe some other time.
Cool.
That was a good example of using your resources, and obviously he has some interest in ultrasound and is a little better than most would be at MSK ultrasound, but especially when it comes to bony irregularities, fractures, we can do a lot of diagnosing and even procedures. Oftentimes when you have a distal radius fracture, we'll use ultrasound to see, I mean, honestly, you don't need ultrasound to do it, but it's fun to see on the ultrasound, and you can do a hematoma block and numb up the wrist before doing your reduction and splinting. And I think it's just a good showing of how EM physicians are often MacGyvers and end up needing to come up with creative ways to solve some of the problems that we encounter. Whether it's because the system is down or you don't have certain resources, there's often times where we are trying to use the supplies that we have to accomplish different procedures and tasks that we just don't have the specific tool we need.
You think I'm on edge? Where's your Shane and Samira? They're McKay.
They both need to be called out for unacceptable behavior.
Yeah, well, you do that in private. Same place you share your thoughts about a patient's possible suicide and slamming stuff. Please, sign out all this shit that's bugging you and get out of here.
I can't.
Yes, you can. When either of my kids was acting like this, I gave them a timeout in their room.
Whoa, you're not my mother.
Yeah? Well, too bad. You need one.
No, I had one. She left. I don't need another one. What I need is someone who can actually run this place while I'm gone.
Okay, I'm sorry. I didn't know.
Nobody knows. Who needs to know? Who gives a fuck?
I think you need a break.
That is what the sabbatical is for.
Let's start it now. Walk away.
I have too much to do.
Let someone else talk to Duke.
No, that needs to come from me.
Why?
Because I owe him that. It needs to come from a friend, not a stranger. Otherwise, he's gonna bail and drop dead while I'm gone.
Okay, wrap that up and then leave.
It's not just Duke. I'm not sure that Alashimi is fit to run this place.
What's that supposed to
I'm
mean?
not sure. I'm trying to figure that out. Did you know that she wants to have 2 attendings on at all times?
No.
Is that something she's worked out with Gloria?
I don't know.
I also don't know if Langdon is going to relapse. I don't know if Whitaker is going to be able to take care of my shit. I don't know if Javadi's going to give up on what she's good at or if Samira's going to flame out because of some bullshit with her mother.
Is there anything else?
Yeah, you. I don't know about you running around with a full syringe of Versed in your pocket. I'm worried about the people that I care about.
We'll all manage until you come back. We always do.
Yeah, what if I don't come back?
Well, it seems that Dr. Robbie's mental health is kind of where everyone has been assuming that it was and is going, and I couldn't help but notice there when he was explaining all of the things that he has, like loose ends to tie up and things to figure out before he can sign out and leave. all seem to be things that are largely out of his control. And I think that having some even just like professional coaching on top of counseling and getting on top of his mental health could help him a lot when it comes to how much of his job he lets consume his life. And I just really hope that he is able to get the reprieve that he needs from his sabbatical. But honestly, I don't know that he's going to make it there before the end of this season. So another great episode. We've got 2 left. We'll catch you in the next one.